Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important session. As you can see that today we are going to read about immune checkpoint inhibitor. Now this is a very commonly asked long answer question in the exams, and it has been asked, increasingly asked in the last 2-3 years. So let us understand what is the concept of immune checkpoint and what is the role of immune checkpoint inhibitor in the treatment of cancer. So before we go into the main topic, first of all we are going to revise certain concept which we have already learned in our general pathology lectures, especially the topic of immunological tolerance. So as you all know that what is immunological tolerance, it is basically a phenomenon of unresponsiveness to an antigen. So basically whatever self antigens are there in the body, our immune system, they have a tolerance towards self antigen. Self tolerance is a lack of responsiveness to an individual's own antigen. So this tolerance, if you see, there are two types. One is the central tolerance, one is the peripheral tolerance. And the mechanism of this tolerance we have already read in detail. Like the mechanism for central and peripheral tolerance we have already read. What we are more interested as of now is to understand the concept of this energy. So we will revise this concept because immune checkpoint is associated with this concept. So let us understand about energy. Energy basically means failure to respond. So before we understand what is that, whenever an antigen presenting cell, this is an APC, for example, can be a macrophage or can be a dendritic cell, any. So any antigen presenting cell, whenever they present to the T cell, then there are two signals which are involved. The first signal is the signal number 1, wherein the MHC antigen is presented by the APC to the T cell receptor of the T cell, and this is constituting the signal number 1. So again I will repeat, signal number 1 is basically MHC antigen on APC which is engaging on the T cell receptor. This is the signal number 1. Then there is another signal, that is the signal number 2, which is a co-stimulatory signal. And now remember, this signal number 2 is very important because for activation of this T cell, both signal 1 and 2 has to be adequate enough. If signal number 2 is not adequate, then activation of T cell will not occur. So what happens that on the surface of T cell we have something called as CD28, which is engaging certain ligand on the APC called as B71, also called as CD80, and B72, also called as CD86. So CD28 on the T cell is engaging the ligand B71 or B72, that is CD80 or 86 on the antigen presenting cell, and once they engage with each other, there is an adequate enough signal number 2, and this will lead to T cell activation. Remember this point. So what is very important, because of any cause, if this signal number 2, if the co-stimulatory signal, they are not adequate during antigen presentation, then the cells become energic, meaning that the T cells will fail to respond against this particular antigen. So this is the antigen presenting cell over here. This is the B7172 ligand, that is the co-stimulatory molecule present on the antigen presenting cell. This is the CD28, which is a co-stimulatory molecule present on the T cell. Only when these two are engaged with each other that the signal number 2 will become strong, and that will lead to a T cell activation. So what is very important over here that you have to know, so this is the antigen presenting cell. So whenever the antigen presenting cell is presenting a self antigen, then the B7 ligand, which is a co-stimulatory molecule, the levels of B7 will come down, will fall down. And whenever the T cell is encountering self antigen, instead of CD28, one other group of receptors or ligands are going to show, that is CTLA4 and PD1 levels will increase. Now remember one thing, this CTLA4 and PD1, they are inhibitory receptors present on the T cells. Just like the CD28, you have presence of CTLA and PD1 receptors on the surface of the T cell. But remember one thing, the actions of CTLA4 and PD1, they are opposite to that of CD28. That is, they are inhibiting the T cell activation. In return, that means they are inhibiting the immune response. So their actions are opposite to CD28. So remember this point. CTLA4 and PD1 are inhibitory receptors present on the T cells, and they are very much similar to the CD28 molecule, but their actions are completely opposite to each other. CTLA4 and PD1, when they are engaged, okay, then in that case there will be inhibition of immune response, there will be inhibition of T cell activation. Okay, so remember this point very clearly. Okay, so basically over here, as we can appreciate, that whenever a self antigen is there, is basically presented by the antigen presenting cell, the levels of B7 co-stimulatory molecule, this B7 on APC, this level of B7 will come down, and on T cell, instead of CD28, okay, CTLA4 or PD1 receptors will be upregulated. So what happens, because of this reduced amount of this B7 and because of increased amount of this CTLA, what is happening is that there is a T cell inactivation. There is a T cell inactivation. So there is no immune response. So whenever there is a self antigen, there will be increased amount of CTLA4 and PD1 on the T cell, leading to reduction in the T cell activation. So there will be no response against the self antigen. On the other hand, if suppose the antigen presenting cell is presenting a microbe, the levels of this co-stimulatory B7 molecules on APC, this is going to increase. This B71 or B72 level, just let me clear it out so I can explain it in more better way. So whenever a microbe is being presented by the APC, this level of B7 ligand will increase, and the CD28 levels will increase, and this CD28 expression will increase. And what is the role of CD28? This is going to augment the co-stimulatory signal and lead to T cell activation. So whenever the microbe is presented by the APC, there will be increased amount of CD28 expression, leading to activation of the T cells. Okay, remember this point. Remember one more thing, CTLA4 has a higher affinity for B7 molecules as compared to CD28. CTLA4 is preferentially engaged when levels of B7s are low. Okay, so just to summarize what we have learned right now, so whenever a self antigen is presented on the surface of APC, the level of B7 ligand is going to reduce, and the level of CTLA4 on the T cell will increase. Okay, this will lead to energy, that is, there is no T cell activation. So T cells will fail to respond. So there is no immune response. On the other hand, whenever there is a microbe, okay, so on the surface of the ABC, that is the antigen presenting cell, the level of B7 ligand will increase. Okay, and on the surface of T cells, the level of CD28 will increase. That will lead to T cell activation and a positive immune response. So this concept should be completely clear, that so these are actually the immune checkpoints. Okay, these receptors, that is CTLA4, CD28, PD1, whenever these receptors are present, they are acting as an immune checkpoint because they are regulating the immune response. Either there can be an increased T cell activation or there can be reduced T cell activation. Okay, so now with this concept in mind, we are going to start off with our topic, immune checkpoint inhibitors. So basically, immune checkpoint inhibitors, they are a form of cancer immune therapy. So what is an immune checkpoint? So immune checkpoint is nothing but it is an immune cell surface receptor. Like for example, we read about PDL1, okay, or we have read about your CTLA4, okay. So these are basically certain receptors, okay. This is like for example PD1 is there or CTLA4 is there. So these are immune cell surface receptor which are involved in activation or inhibition of immune response, even CD28, okay. So these are involved in either activation, this one will activate the immune response, whereas when these are activated, they are going to inhibit the immune response, okay. They will inhibit the immune response, okay. CD28 when activated, they will stimulate immune response. PD1, CTLA4 activated, they will inhibit the immune response, okay. So this is basically an immune checkpoint. How does the immune checkpoint inhibitor function? So they function by blocking the inhibitory immune checkpoint. So these checkpoint PD1 and CTLA4, they are inhibitory because they will inhibit the T cell activation. So this PD1 and CTLA4, these are the inhibitory. So if by any chance we block these, if we cause blockage of these receptors, that is going to lead to increased T cell activation, okay. So how does the immune checkpoint inhibitor function? They function by blocking the inhibitory immune checkpoint. So these are the inhibitory immune checkpoints, okay, thus restoring the immune function against cancer cells. So basically the immune checkpoint inhibitor therapy, in this immune checkpoint inhibitor therapy, what we are using the patient's immune system to kill the cancer cell. This is what the basic mechanism is, okay. So how do we do that? We inhibit the inhibitory immune checkpoints, okay, thus we restore the immune function against the cancer cell. Now, most important checkpoint inhibitor therapy in place that we see right now, there are two categories. One is the PD1, PD-L1 inhibitor. Now, remember one thing, PD1 and CTLA4, they are expressed on the surface of T cell. Okay, they are expressed on the surface of T cell, whereas PD-L1, they are expressed on the surface of neoplastic cancer cell. I will show you with the help of diagram, don't worry. So, we are having two class. One is PD1, PD-L1 inhibitor and one is CTLA4 inhibitor. So, these group of inhibitors, they are inhibiting PD1 and PD-L1, and these are in the form of humanized monoclonal antibody. CTLA4 inhibitors, they are basically causing the T cell modulation in the early phase of activation of T cells, whereas PD1 and PD-L1 inhibitors, they are basically causing T cell modulation at a later phase. Okay, so what is the mechanism of action of T cell inhibitors? Let us try to understand. So over here is a T cell, okay, which is basically engaging an antigen presenting cell, as we have already seen previously. This signal wherein the MHC is engaging the T cell receptor, this is the signal number 1 that we already know, and this is the signal number 2, that is a co-stimulatory signal. As we have already read, whenever the B7-B72 ligand is engaging the CD28, okay, they will activate the T cell, but whenever these ligands are engaging CTLA4 on the surface of T cell, they will inhibit the T cell, right? So basically the basic mechanism is we have to inhibit, we have to block the CTLA4. Once we block the CTLA4, there will be T cell activation, and this T cell is going to go and kill the cancer cell. So this is the mechanism of CTLA4 inhibition. Now remember, cancer cell, they are expressing something called as PD-L1. Okay, so this is again the signal number 1 on the T cell cancer cell. So MHC on the surface of cancer cell, they are engaging the T cell receptor on the T cell. So this is signal number 1 and this is the signal number 2. So in the cancer cell, they are having certain ligands called as PD-L1 ligand, which is engaging a receptor, that is PD1 on the surface of T cells. Okay, so over here you either block this receptor, that is PD1, or you block this ligand, that is PD-L1. So either of these two, if you block, then this second signal will not go, and once these two are blocked, there will be unchecked T cell activation. So there will be T cell activation, and this T cell is going to go and kill the cancer cells. So in both the condition, we have to block those receptors which are usually inhibiting the T cell response. So we are inhibiting CTLA4, PD1 or PD-L1. As a result, the T cell is unchecked activated. As a result, they can kill the cancer cells very effectively. So there are two interactions, CTLA4, okay, CTLA4, normally remember this CTLA4, when they interact with the B71 or B71 or 2 ligand, okay, then there is inhibition of T cell immune response. Similarly, whenever PD1 is interacting with the PD-L1 ligand, there is inhibition of T cell immune response. Okay, now if in any way we are blocking these receptors, okay, or this ligand, if we block this receptor, these are the receptors, or these ligand, so what is going to happen, that these checkpoint inhibitors are going to block these receptors and ligand, and they will act by increasing the immune response, thereby facilitating the killing of the tumor cells by the patient's immune cells via T cell response and tumor regression. So what are the immune checkpoint inhibitors which are widely used? So the most commonly used group of inhibitors include CTLA4 inhibitor, including ipilimumab. Then there is PD1 inhibitors, which includes pembrolizumab, nivolumab, cemiplimab, and then there is PD-L1 inhibitor, including atezolizumab, avelumab, and durvalumab. Okay, so these are the checkpoint inhibitors which are commonly used, and these names at least you have to remember and write down in the exams if you want to score points. So first we are going to read about the CTLA4 inhibitors. So first you have to understand that the CTLA4 molecule, they cause negative regulation of the T cell activation via interaction with the B71 and B72 ligands. Now CTLA4 binds with this B71 and 2 with greater affinity than CD28, leading to negative signaling of the T cells normally. So CTLA4 inhibitors like ipilimumab, these are human IgG1 monoclonal antibody directed against CTLA4. So they will go and block the CTLA4, and it is the first anti-cancer drug targeting the immune checkpoint, and it was devised and approved for melanoma in 2010. Now after using this drug, it was seen that it significantly increased the survival there was a durable response for more than 2.5 years with a long-term disease control. And very importantly, this regulates the T cell activity at early or priming phase, as I have already highlighted. So blocking of the CTLA4 will lead to increased T cell response, okay, against the cancer cells. Second group is the PD-1 receptor inhibitor. Okay, PD-1, what is PD-1? It is the programmed cell death 1 protein expressed on the surface of the T cells. It binds with the PD-L1 ligand which is present on the surface of cancer cells, and this leads to T cell inhibition and exhaustion. So this is how normally the cancer cells, they escape our T cells, because cancer cells are exhibiting PD-L1 ligand on the surface. They will engage the PD-1 receptor on the T cells, and once they are engaged, there is the inhibition of the T cells. So T cells will not going to act. So suppose we create a mechanism of inhibiting this PD-1 receptor. In that case, what will happen? The PD-L1 ligand will not be able to engage the PD-1 receptor because that is blocked. As a result, the T cell will be activated and they will act against the cancer cells. Okay. Now remember, this PD-1 receptor is more widely expressed as compared to CTLA4 on the surface of the T cells. Now PD-1 inhibitors, they regulate the T cell activity in peripheral tissue at the later stage, okay, at a later stage of T cell activation. Now what are the group of drugs under the heading of PD-1 inhibitors, PD-1 receptor inhibitors? Okay, it includes pembrolizumab, nivolumab, cemiplimab. All of them, they are humanized IgG4 monoclonal antibody. Now pembrolizumab, they are approved for the treatment of melanoma, non-small cell lung carcinoma, head and neck squamous cell carcinoma. MSI means microsatellite instability high, MSI-H solid tumors, triple negative breast carcinoma. TMBH means tumor mutation burden high or defective mismatch repair protein associated endometrial carcinoma, cervical carcinoma, and late stage gastric carcinoma. Whereas if you see nivolumab, it is basically approved for melanoma, non-small cell lung carcinoma, head and neck squamous cell carcinoma, MSI-H, DMMR, colorectal carcinoma, Hodgkin's lymphoma, hepatocellular carcinoma, renal cell carcinoma, esophageal squamous cell carcinoma, pleural mesothelioma. And lastly, cemiplimab, it is basically approved for treatment of cutaneous squamous cell carcinoma. Okay, the full form which I have already explained, I am not repeating again. The next group of drug include PD-L1 inhibitor. Now remember, PD-L1 was what? It was a ligand on the surface of the cancer cell. So PD-1, okay, PD-1 suppresses the T cell activation via interaction with its ligand, that is the PD-L1 and PD-L2. Now PD-L2 is expressing on the dendritic cell, whereas this PD-L1, they show increased expression in a variety of cancers. So as a result, if there is an increased expression of PD-L1 in the neoplastic cell, they will engage the PD-1 receptor, okay, on the surface of the T cells, and because of that engagement, there will be decreased T cell activation, leading to increased proliferation of the neoplastic cancer cells. Now 3 FDA approved PD-L1 inhibitor include atezolizumab, okay, durvalumab and avelumab. Now all of them, if you see, they are humanized IgG1 anti-PD-L1 monoclonal antibody. Atezolizumab, they are approved for urothelial carcinoma, non-small cell lung carcinoma, small cell lung carcinoma, melanoma and hepatocellular carcinoma, whereas durvalumab is approved for urothelial bladder carcinoma as well as non-small cell lung carcinoma, small cell lung carcinoma, biliary tract carcinomas, whereas avelumab is approved for Merkel cell carcinoma, urothelial carcinoma and renal cell carcinoma. Okay, so these are the 3 main group of inhibitors, that is the checkpoint inhibitors that we know of. In addition to above immune checkpoint, there are other checkpoints which can be blocked. For example, TIM3, LAG3, VISTA, CD134, GITR, etc. Okay, so these are the important group of checkpoint inhibitors. Now we will read about what are some of the important predictive biomarkers for predicting the clinical response to checkpoint inhibitors. The short form is CPI. Okay, remember. So why is it needed? So although the use of CPI has shown promising results, only 20 to 40% of the patients are showing evident benefits. So there are certain factors which are deciding on the response to checkpoint inhibitor therapy. So we have to identify those factors. Okay, why we have to identify? Because the treatment is very expensive. So if a particular treatment is not going to benefit the patient, Okay, so why do we waste so much money on that? So that is the basic rationale. And the treatment and also this checkpoint inhibitor therapy is also having a side effect. So that is why we should not use it just like that. We have to do certain tests before we administer checkpoint inhibitor therapy to the patient. Therefore, it is necessary to carry out certain investigation to predict the clinical response to checkpoint inhibitor. Okay. So number one, let us see the first factor, the first biomarker which is predictive of response to checkpoint inhibitor therapy. Now, number one is the PD-L1 expression. So its expression on both the tumor cells and immune cells is measured by IHC. Mainly, currently it is done on the tumor cells. So based on the IHC, the patient is given a tumor proportion score called as TPS score, which is nothing but it is the percentage of tumor cells which is expressing PD-L1. So TPS is basically a tumor proportion score, which is nothing but it is the percentage of tumor cells which are expressing PD-L1. So example, non-small cell lung carcinoma patients with a TPS of more than equal to 50%, they show longest progression-free survival and overall survival with PD-L1 inhibitors. Okay. The second important deciding factor is the tumor mutation burden, TMB. It is defined as the number of mutation per megabase in cancer cells. High tumor mutation burden called as TMBH is associated with increased response to immune checkpoint inhibitor therapy. Example, solid tumors with a high TMB, tumor mutation burden, that is more than equal to 10 mutation per megabase, shows a significant response to pembrolizumab. Okay. Number C, defective DNA mismatch repair, okay, and microsatellite instability. Now remember, normally the DNA mismatch repair system repairs any intrinsic errors during DNA replication. A defective MMR like dMMR leads to microsatellite instability, leading to accumulation of multiple maladin mutation, which is going to facilitate tumorigenesis and neoantigen production. Okay. Now very importantly, since therefore dMMR or MSI leads to increased immune cell infiltration, leading to increased susceptibility to checkpoint inhibitor therapy. So this is the importance of microsatellite instability. So those cancers, the tumors showing increased MSI or increased dMMR will lead to increased immune cell infiltration or increased susceptibility to checkpoint inhibitor therapy. Example, patients with MSI, H or dMMR shows significant response to pembrolizumab. Okay. Now number D, if you see the fourth important factor for biomarker for predictive response to checkpoint inhibitor therapy is TME, that is the tumor microenvironment. It is a reservoir of blood vessels, immune cells and inflammatory mediators which are surrounding the tumor. Now tumors with increased levels of tumor infiltrating lymphocytes, okay, they are considered to be hot and they are more susceptible to treatment with checkpoint inhibitor therapy. Immunoscoring characterizing the presence of CD3 plus and CD8 plus T cells are considered tool to predict prognosis and response to checkpoint inhibitors. Example in colorectal carcinoma, breast carcinoma and hepatocellular carcinoma. Fifth important factor is microbiota, which is the microorganisms inhabiting a specific environment. It alters the efficacy of the immune response to vaccines or cancer therapies, okay, like checkpoint immunotherapy. Microbiota induces immune response via increased secretion of interleukin-2 or interferon gamma and direct activation of T cells, leading to killing of the cancer cells. Loss of microbial diversity, also called as dysbiosis, will lead to poor response to checkpoint inhibitor therapy. Alternatively, microbiota transplantation is associated with better response to checkpoint inhibitor therapy. Example in patients with melanoma or hepatocellular carcinoma. Now, what are the adverse effects of checkpoint inhibitors? They are called as immune-related adverse events. This is the short form. Most common adverse effects includes fatigue, 34%, then anemia, 45%, and dysphagia. They are associated with all grades of adverse effects and may be associated with it. So, all grades of adverse effects may be associated with it. Okay. Life-threatening immune-related adverse events are less common and include de novo insulin-dependent diabetes mellitus, pituitary dysfunction leading to endocrine disorders, inflammatory pneumonitis, renal nephritis, eye damage, mortality. Late immune-related adverse events are those which occurs more than 12 months after inducing checkpoint inhibitor therapy. The treatment of these adverse effects includes corticosteroids mainly, plus minus TNF inhibitors, plus minus mycophenolate mofetil. Also, ASCO recommendations for the treatment depends on the grade of immune-related adverse effects. So, grade 1, you should continue the use of CPI with close monitoring. Grade 2, stop the checkpoint inhibitor therapy, return to CPI or return to treatment only when the grade changes from 2 to 1. Grade 3, stop the CPI, start with high dose corticosteroid. Grade 4 is permanently stop CPIs. Now, novel delivery approach, what is that? It is a type of delivery approach to combat the unpredictable adverse effects and to concentrate the delivery of checkpoint inhibitor only at the tumor site, so that unwanted adverse effects are not there in other organs. So what are some of the novel ways that you can deliver these checkpoint inhibitors? In the form of nanoparticles, matrix binding molecular conjugates, engineered biomaterials, viral vector systems, and bacteria. So with this, I think you have enjoyed this session, a very high yielding topic for this year's exams as well as for the next 2-3 years. This will be a very hot topic. So thank you for watching this particular video.